Everybody, and welcome to our second seminar. Today I'm going to talk about your routine blood tests, what, why and when. So first of all, a question that quite a few people ask me is, why do we have to have blood tests done? Well, really having bloods is the best way of monitoring your health and treatment. So it can monitor how you respond to treatment, whether you're getting any side effects from your treatment. Assess if when you're unwell. We can do bloods to assess your health then. We can diagnose other infections through blood tests like hepatitis, and also we can measure your response to vaccines. So if you had a vaccination for hepatitis B or measles or mumps, then we can make sure that you become immune. And also we can use them to monitor your general health like cholesterol and diabetes. So another common question we have is, are you taking too much blood from me? Some people get very upset and think that we're draining them of blood. So I want to reassure you that no, we're not. So I don't know if you know, but the average adult has 5 litres, that's 5,000 mils of blood in their body at any one time. So when I take that little tray of blood, I don't know if you can see the little tray of blood there, with your routine tests, we take a maximum of 30 mils of blood, which is about 0.6% of your total blood volume, so not much at all. And as long as you have a drink after your blood test, you replace the lost volume within an hour, so we're not taking too much blood out of you. And another thing I get from patients as well is, I really hate blood tests. Well, what I have to say to you is, no one comes in saying, goody goody, I'm having a blood test today. A lot of people don't like having their bloods taken. It's a necessary evil. So I'm just going to give you some tips about having your bloods done. So first of all, you're not alone. A lot of people are very frightened about having their blood tests done and have what they call a needle phobia. But what you need to do is just tell your nurse that you're worried, because we're really used to people who hate needles, and we can be very supportive. But sometimes what you can do is just bring something in to distract you. So some people put their earphones in and listen to music. Some people have a friend in and they talk to them, or some people just shut their eyes and do some deep breathing. And we also have a nurse on hand who can hold your hand if you'd like us to. The main thing you should really do is make sure you have plenty to drink and something to eat before you come for your bloods. Obviously, if you're having fasting bloods, so you're doing a cholesterol level, you can't eat, but you can definitely drink. So black tea, black coffee, water, drink as much of it as you can, because that plumps up your veins and make it much easier for us to take your blood. And really, please don't come in after you've had a late night or been partying. And a lot of people I find, if they hate having their bloods taken and a bit nervous about coming to clinic, tend to go out for a little bit of a session the night before, and then they come in, they're feeling a bit hungover and a bit tired, and actually and dehydrated, so it's much more difficult for us to take blood. So don't come on a Monday morning after a Sunday night out. And if you think you're going to faint or you feel faint, don't be embarrassed, don't be shy. It's better that you tell us, and then we can lie you down in one of the beds, and so you don't faint, and we can look after you afterwards. And I suppose it's easy for a nurse to say, try and be brave, but try and be brave, try and relax. Actually, it only takes a very few seconds, and often the thought of the thing is actually worse than the experience itself. I will have to say, we do have patients who have terrible needle phobia, and we do have psychologists that can actually help with this. And I had one chap who couldn't even get in the room, even in the blood test room, and then he saw the psychologist for some sessions, and now actually, although he still finds it difficult, he can actually manage to sit in the chair and have his bloods done. So if it's really bad, let us know and we can try and help you. Okay. So what I decided to do today was just talk about the routine blood tests that we do. So the ones that when you come to clinic before you see the doctor, the ones that we will routinely do for most patients. There are lots of other blood tests that we do that are quite complicated, but we've only got a short length of time today, so I'll just go through these. So most people have an HIV viral load done. You also have a CD4 count done a minimum of once a year. We'll check how your liver's working, we'll check how your kidneys are working. And we'll also do something called a full blood count. So what I thought I would do is explain what these tests are for you today. So I just thought first of all talk about HIV-specific blood tests. So the main one we do is a viral load. And really what a viral load does is it measures the amount of HIV genetic material that's in your blood. And the genetic material we measure is RNA, and that's what we measure. It's reported as the number of copies of HIV RNA in a milliliter of blood, so a very tiny amount of blood. Although we take two bottles, they have to spin it down and concentrate it, so that's why it's only in a mil. And a viral load in people who don't have HIV, aren't on HIV treatment, can range from hundreds, thousands, tens of thousands, hundreds of thousands, or even into the millions. So what would a viral load tell us? Well, a viral load will tell us how likely it is for HIV to progress. So when you first get diagnosed with HIV, we'll do an HIV viral load, and the higher the HIV viral load is, the more damage that will be happening to your immune system. It also tells us which medication we might use. Some medications we can't give to people who've got a high HIV viral load, so it helps us decide which medications will be best for you. It measures really how effective treatment is, and I'll talk about undetectable viral loads in a moment. But it also tells us maybe if your treatment's not working, and that we may need to look at what's happening with your medication. So maybe we need to look at adherence, your drug interactions, drug levels, or whether you've developed some drug resistance. And finally, we can use it to indicate transmission risk. So if you've got a very low viral load in your blood, it probably means that you have very low infectivity. And I know one of my colleagues is going to do another talk about the risk of exposure to HIV, so I won't go into that too much today. So viral load is very much linked to HIV treatment. So really the aim of HIV treatment is to get your viral load down to a very, very low level, and that will stop the damage to your immune system. We would expect your viral load to become very low, or what we call undetectable, 3 months after starting treatment. And once your viral load is undetectable, then we'll just routinely monitor it every 6 months when you come to see us in clinic. And most people on antiretroviral therapy, if they're taking it properly, will remain undetectable on treatment for many, many, many years. And we have people who've been on treatment for 20 years with the same drugs and they're still undetectable. So then I thought about some of the common questions I get asked about HIV viral load. So the main one I get is, oh great, my viral load is undetectable, does that mean I'm cured? Unfortunately it doesn't, okay, so I just need to explain why that is. So I'm going to read off my slides, so bear with me a second. So viral load tests have a cut-off point below which they cannot be reliably detect HIV. It's called the limit of detection. So just because the level of HIV is too low to be measured by the blood test, it doesn't mean that the HIV has completely disappeared from the body or your blood. So HIV may also be present in other parts of the body, like the gut or the lymph nodes or the genital tract. So as soon as you stop taking HIV medication, your viral load will rise and it will go back to the pre-treatment levels. So undetectable doesn't mean the virus isn't there, it just means that the test can't detect it. Does that make sense to everyone in the audience? Good. So that, I have to make that quite clear, because I have had people in the past who said, oh great, my viral load is undetectable, I'm cured, and they've stopped taking their medication. So it's just important to bear that in mind. The second question I get a lot about viral load is, help, the nurses have called and told me I have a viral load blip, should I be worried? And the short answer is probably not. As long as you're taking your medication properly, and the viral load should be undetectable when repeated. And there's this little graph on there, and basically what it shows, you can't really see it very well, is that when people are taking their HIV medication properly, the virus usually remains under control, but once in a while it'll just blip up, and then naturally go back down to undetectable again. And it just happens that we'll be taking your blood when you're having that little bit of a blip. So a blip in itself is nothing really to worry about, but it is important that you come back to see the nurses, to have their blood repeated, just to make sure that's what it actually is. Does that make sense? Yeah. Good. So the other common question I get about the viral load is, help, the nurses have called me and told me my viral load is still undetectable after a blip, and then should I be worried? Now, that is a bit more of a concern, depending on how high the viral load has gone up. It could be that your treatment's not working and you're having what we call a viral rebound rather than a viral blip. So then we would do more tests, like resistance tests or drug levels, or check your adherence, etc. And maybe talk to you about switching medication. So again, that little graph on there shows that someone's been undetectable, and then it's gone up, the dotted line is the limit of detection. They become detectable, and then it's just continued to rise, and that means that the treatment actually isn't working. So rebound is different to blip. Okay. So the second blood test that we use to monitor HIV specifically is the CD4 count. So the CD4 cells are T helper cells, which are white blood cells that organise the immune system in response to infections. And basically, HIV mainly targets CD4 cells to replicate and use it as a factory. And really, the level of your CD4 will indicate the well-being of your immune system. And CD4 is measured in cubic millimetres, and the normal count in someone who doesn't have HIV can range between 500 and 1,500. If your CD4 count is less than 200, then you're at risk of becoming unwell with HIV and opportunistic infections. And we also do a CD4 percentage as well, so that's the proportion of white cells that are CD4 cells. Now, percentage in adults doesn't really tell us terribly much. They use it much more in children, but sometimes if your CD4 count has dropped for any reason but your percentage remains the same, then we don't worry so much about the drop in your CD4. So thank you very much to NAM. I pinched this picture from them, and this is like a dog chasing its tail, which describes the life cycle of HIV and how CD4 cells are destroyed. So basically what happens is the CD4, the HIV infects the CD4 cells and uses it to make more of the virus. And number two is your body makes more CD4 cells to help fight the HIV, but the new CD4 cells targets more HIV, so the HIV infects more of those cells. And each cycle of this gradually weakens the immune system, so it's a dog chasing its tail. So when you have treatment, and I'm going to have to put my glasses on because I can't see my slide, the viral load becomes undetectable, and then your body stops overproducing the CD4 cells, and your immune system can take time to repair. So basically, you stop that cycle of the dog chasing its tail. So CD4 and treatment. Well, CD4 used to be a very important blood test in the early days of HIV before we had treatment, but now and would indicate when we would want to start people on HIV treatment. But actually, new guidelines have just come out to say that we really should be treating everybody, or people should be offered HIV treatment, whatever their CD4 count is, whether it's high or low, or definitely even if it's high. So that's what we do now. But some people don't want to start treatment, or they've got reasons why they don't want to start. But we really would start recommending that you have HIV treatment if your CD4 count gets down to around about 350. That's when you should really be thinking about taking treatment. And a CD4 count below 200 really means that you're going to be at risk of infection. You should start antiretroviral therapy as soon as possible, and maybe have prophylaxis against special kinds of pneumonia. But once your HIV viral load has become undetectable on treatment and your CD4 count has gone above 250, then we stop monitoring your CD4 count, and we probably only do it once a year. So there's a couple of common questions I get about CD4 count. But one is that my CD4 count used to be checked every visit, now it's once a year. I really like knowing my results as it reassures me. Why have you stopped doing this? It's quite a good question, really. But really the answer is that once you've become undetectable in your treatment and your CD4 count has gone above 250, you're very, very unlikely to get unwell with HIV-related infections. And really it's the viral load which is the best way of tracking whether your treatment is working. So the viral load tells us that the drugs are keeping the virus under control. Research has shown that doctors don't change HIV treatment or management based on CD4 results. It's always based on viral load results. So actually, it's not cost effective to keep doing a blood test. That doesn't mean that we change your management at all. So, and if you think a CD4 count costs £60 a pop, and we're doing them unnecessarily, that's money we could save and use on something else. So clinically, not having a CD4 count won't affect the way that you're managed, but we will always do a CD4 count for you once a year. Okay, does that make sense?
Mm-hmm.
Yeah. And then there's other common question about CD4 is that, like someone will say, my partner and I started HIV treatment at the same time. His CD4 count keeps going up, but mine is stuck at 250. Why is this? And people tend to have quite competitive CD4 counts. I hear people in the waiting room talking, oh, my CD4 count's this and mine's that, and people get quite jealous if you've got very high CD4s. But this is what this can happen. But the way that you increase your CD4 counts when you start treatment often depends what your CD4 count was before you started. So if people have a low CD4 count before they start treatment, they're much less likely to recover their CD4 cells than people who started at higher levels. And what happens is most people just reach a plateau of their CD4 count, and then it just remains stable, so it doesn't incrementally rise. So just to reassure people though, but being on antiretroviral therapy, whatever your CD4 count is, will protect you from HIV-related complications. So actually, once you're on treatment, it's actually the being on treatment, not your CD4, that seems to be protecting you from getting unwell. So it's something not to worry about, okay? So we've done the CD4 count and the viral load, so now we're on to the sort of monitoring test that we do every time that you come and see us. So we always do a liver function test, and just to say that the liver is one of the most important organs in your body. It has about 20 different processes that it carries out for you, but really mainly it's a good old waste disposal unit for your body. It gets rid of all the nasties and the toxins. So you need to look after it because you've only got one. If you damage a kidney, you've got another one, but with a liver, you've only got the one. So we want to keep your liver working in good working order. But the problem we have is that many HIV drugs and other drugs are processed through the liver. So the liver is under stress when you're on HIV therapy. And very occasionally, these drugs can cause damage to the liver. Nevirapine, for example, can cause liver damage. But the other things can cause damage to your liver as well. Alcohol is the main one, plus some recreational drugs. And infections such as viral hepatitis, so hepatitis A, B and C, cause inflammation of the liver. That's what hepatitis means. And also being overweight or having high fat levels in your blood, so maybe you've got lipodystrophy or lipoatrophy, the fat collects in the liver and you develop what's called a fatty liver. And if the liver's full of fat, a bit like foie gras, it's not working as well as it could do. So we see quite a lot of fatty liver at the moment. So that's why it's really important we keep an eye on your liver function and try and keep your liver healthy. So we do it every time you have your bloods taken. We might need closer monitoring when you start treatment or if you've been diagnosed with a liver problem. So if the liver is under stress or damaged, it produces things called enzymes which show that it's not very happy. You don't need to remember these words, but you might hear them being mentioned by the doctor. So it'll be ALT, gamma-GT or ALP, and these are these enzymes. The other thing that the liver produces is bilirubin, which is made when the body breaks down the red blood cells, or the liver breaks down the red blood cells, and these pass through the liver, and if the liver's not working properly, it can build up in the blood, and that's bilirubin is what makes people go yellow when they have jaundice, is a build-up of bilirubin. Just to rest assured, if you're on atazanavir, one of the drugs that we use, that can cause a natural rise in the bilirubin level. So your bilirubin in your blood will be raised, but there's nothing to worry about. It doesn't matter. It doesn't mean that your liver is damaged. And if you've got a little bit of yellowing in your eyes, that doesn't mean your liver is damaged at all. It's just a side effect of the drug. And then we measure something called albumin, and albumin is a protein made by the liver, and that can be very low in people who've got severe damage to the liver. If you've got cirrhosis or liver cancer, you can have very low albumin levels. So those are the tests that we do. So what happens if your liver function tests are abnormal? Well, it would depend on how abnormal they are. So if they were normal before and they shot up and they're really, really high, then that would be a bit of an emergency. But if they've been normal and just crept up a little bit, or they've always been slightly abnormal, then we probably wouldn't worry too much about it. So it depends. So what we would do is do a risk assessment on some people and then just check them again in a few days. If we think it's related to their lifestyle, we might give advice about reducing alcohol intake, losing weight or diet, especially if you think it's a fatty liver. If we think people are at risk of acquiring hepatitis A, B or C, then we might screen them for infection. And very often the way we pick up, especially acute hepatitis C, is not because we've found the virus in the blood, it's because the enzymes in the liver have risen up and made us think, actually, has this person got hepatitis? And then we go on to check them for hepatitis. If we think it's the medication, we can stop or switch medications to try and protect the liver. If we can't find any particular reason why your liver function is not so great, we might refer you for a scan of the liver, and we might refer you to a liver specialist. So that's your liver, and then the other waste disposal unit in your body are the kidneys. Okay, and you've got two kidneys, so if one goes, then you have got another one. As I said before, some drugs are processed through the liver, but some drugs are also processed through the kidneys. and occasionally these drugs can cause problems with kidney function. And also HIV itself can affect the kidneys, and it's called nephropathy, and it's often found in people who've hasn't had HIV diagnosed and they've had a low CD4, so HIV itself can cause problems. But really the main causes of kidney problems tend to be high blood pressure, diabetes, chronic kidney infections or kidney stones. So there are many reasons why your kidneys might be under pressure. And kidney failure can be acute or chronic. So acute means it happens very quickly. So often if people have become unwell very quickly and become very dehydrated, that can cause what we call acute kidney failure. But mainly the failure is chronic, and it happens over a long period of time. And most people that we see in clinic will have chronic problems with their kidneys, not an acute problem. So we do your kidney function test each time you have blood, and more often if you have a kidney problem. And I've just listed the main things we look at. So first of all, we look at levels of a thing called creatinine. And creatinine is a chemical waste which is usually filtered into the urine through the kidneys. So if the kidneys aren't working properly, that creatinine remains in your blood and isn't excreted out through the urine. Urea is a waste product of protein breakdown. So when you break down your cells, which is a natural thing that your body does all the time, it's usually filtered out by your kidneys. And again, if your kidneys aren't filtering properly, the urea stays in the body. GFR is glomerular filtration rate, and that measures how many millilitres, how many mils of waste fluid your kidneys can filter from the blood in a minute. So basically what the kidneys doing are just acting like a sieve for your blood, and they're filtering out all the bad stuff and keeping all the good stuff. And if they can't do that very quickly, then that means your kidneys aren't working very well either. So the quicker that you can filter through, the better, basically. And then, although this isn't a blood test, I think most patients get the nurses ask them for a urine sample every time they come to clinic. And basically what we're looking for then is if you've got any protein or albumin, which is another type of protein, in your urine. And basically protein is a good thing. Your body wants to retain protein. And if your kidneys aren't working properly and they're a bit what we call leaky, protein will be excreted through into your urine, which isn't a good thing. Okay? So what if your kidney function is abnormal? Well, again, it depends on the levels in the individual patient. So again, we would do a risk assessment and then maybe check them again in a few weeks, and often they'll just go back to normal. But if we're worried, we might stop or switch or change doses of medication. So say, for example, people are on a drug called tenofovir or Truvada, that can cause problems with the kidneys. And if you think that's causing kidney damage, we might switch that. But also if your kidneys aren't working as well as they could do, they're not filtering drugs out very well, we might have to reduce the dose of your drugs. And you need to tell the doctors as well what other medication you're taking, maybe over the counter. So things like Nurofen can cause quite bad problems with the kidneys, and people often don't tell us that they're taking drugs like that, so you need to let us know. So we would then investigate if you might have acute kidney disease. As I said, if it came on quite quickly, if you've got an infection or you're dehydrated, we might bring you to hospital and treat you. If it's more of a chronic picture, then we would investigate things like diabetes, high blood pressure, etc., and make sure you get treated for that. We might offer you a kidney scan if we felt that was important, and then if things weren't getting better, then we would refer you to a kidney specialist. So the last test that we do, which goes in this little bottle here, is what's called a full blood count. And when you get a full blood count report, there's about 10 different things that they report on it, but I've just concentrated on 3 most important things. So first of all, it measures hemoglobin, and basically hemoglobin is in the red cells, and that carries oxygen around your body. You have white cells in your blood as well, and they help fight off infection. And then we have platelets in the blood which help clot. If you cut yourself, it helps clot. We usually do them once or twice a year. Since the HIV drugs have got so much safer, they don't tend to damage or have an impact on your full blood count as much as they used to. So in some people, you only get it done once a year. So haemoglobin, or you might be heard it might be called HB. Mainly the thing we see, it's in low levels. And basically, haemoglobin is made of iron particles. And so if you don't have enough iron in your diet, then you become anemic. You don't have enough red cells going around your body. So often it can be iron deficiency. So if you're not eating enough leafy green vegetables, or you're not eating red meat or vegetarian, some people become iron deficient. Some medications can cause problems in how the red cells and the haemoglobin are made in the bone marrow. Sometimes you can be anemic because you're having chronic bleeding, and this can be heavy periods in women, or it could be that you have an ulcer in your stomach that's gradually that's bleeding, but you're not noticing any symptoms. So sometimes that can cause anemia. Chronic renal failure can cause anemia, and very often, if you're low in things called like folic acid or vitamin B12, again that's used with the iron to make the haemoglobin. That means that you can be anemic. Pregnancy can cause anemia, and something called hemolysis can cause anemia as well. So basically what happens is, if you take a drug, for example, I think the drug called ribavirin, which we use to treat people with hepatitis C, that causes you to break down your red blood cells much more quickly than you normally would, and it takes the body a lot longer to try to make those new cells for you. And again, if you've got problems in your bone marrow, so basically most of your cells are made in the bone marrow, and if that's not working properly, that can cause anemia. Usually when we do blood tests for people and they're anemic, it's usually around iron deficiency or folic acid or vitamin B deficiency, so we would give people supplements for that. If they didn't respond to that, then we would investigate further. And then your white blood cells, well, there's two types of problems with your white blood cells. You can have raised white blood cells, we call that neutrophilia, and that can happen if you have an infection, or very rarely if you have leukemia. So say if someone comes in and they're short of breath and we think they might have a chest infection, if you do their full blood count, their white cell count will be raised, and that's because your body's trying to produce cells to fight off an infection. So that would help us diagnose the fact that you have an infection with a bacteria. It's usually bacteria that does that. And low white cells, or leukopenia, that happens quite often. Sometimes it's again with bone marrow problems, because your white cells are made within your bone marrow, but often it can be related to chronic viral infection, and HIV is a chronic viral infection, so we often find that people with HIV will have a lower white count naturally anyway. But also it can be genetic, so people from an Afro-Caribbean black background or black African background can sometimes have a naturally low white cell count, and actually doesn't seem to do them any particular harm. It upsets the doctors that it's low, but actually it's not harmful. And finally, our platelets. So really, if you have low platelets, it means that if you cut yourself, or you fall over, or you have a bleed inside, then your body can't clot the blood, and it can lead to bleeding problems. Low platelet count can be caused by many things, and often it can be caused by viral infections. And some people who have HIV have very, very low platelet count. So even though their CD4 counts are very, very high, we often give them HIV medication to bring up that platelet count. If you have liver problems, especially if your liver is very damaged, what we call cirrhosis, the liver does help produce platelets, and sometimes the platelets can drop if you've got a bad liver problem. And sometimes it's called an autoimmune condition, so sometimes your body will fight itself basically, and sometimes the body doesn't recognise platelets as being a good thing, but think it's a bad thing, and the body destroys more platelets than it can actually make. And then some people have a high platelet count, and that can be caused by inflammation, infection, or bone marrow issues, but again, it's very rare we see that. We usually see low platelet counts. So really that's just an overview of the regular blood tests that we do, and I was just going to finish off by just answering some sort of practical questions that you might have about having blood tests. So how do I get my blood tests? Well, it's usually better to receive and discuss your results face to face. It's always much easier to do that. So it's really important to try and get your bloods done a week or so before you have your appointment with your doctor or your nurse, so that when you come in to see the doctor or the nurse, they've got them there and they've got results to talk to you about. That's quite important. The nurses can give you blood results over the phone, but you may need to speak to a doctor if the results are abnormal or it's more complex or an unusual test. So ideally we'd prefer that you came and got your results face to face. Just to let you know that we wouldn't routinely ring you back with blood test results unless we made a prior arrangement with you to do that. So if you'd like to know, if you had your bloods done, say when you saw the doctor, and you'd like to know the results, then you need to give the nurses a call. If you think we've got 1,600 patients, I think, coming to the clinic, and each of them will at least have blood tests twice a year, so you can imagine the volume of blood test results that we're dealing with. So it's really important that you phone us, we won't be phoning you. Okay. And of course, all your results will be checked by a nurse or a doctor. So just because you don't hear from us doesn't mean no one's looking at your results, it's just that they're okay. So there's a process involved. So if you look at your bloods and we think there's something abnormal or something that needs action, so your liver function's changed or your CD4 count's dropped or whatever, one of us will pick that up and ring you and let you know and ask you to come back to the clinic to have that repeated. And this is something that I think is quite important, and I think it can happen with people who are newly diagnosed, it can happen with people who are diagnosed for a very long time. They may not really understand what the blood test results actually mean. And I think it's really important because these results are your results. They're not my results, they're not the doctor's results, they're your results. So you please ask us. If you're not sure, ask us. We're really happy to explain. Or if you don't really want to ask the doctor, you're a bit embarrassed, you've seen the same doctor for 20 years and you've never asked them what a CD4 count means, don't be shy, just ask one of us and we'll be also really happy to help. Pharmacists can help you and so can the nurses. And just to say that NAM, National AIDS Manual, have very good booklets about blood tests, and these are available in the clinic if you'd like to read them. And you can also have access to their website. I'll put the details up there for you. And they have very clear explanations about blood tests. But you know, if you're not sure, please ask. And I suppose the final thing is about keeping track of your results, because they are your results. And it's quite important to know what's happening with your CD4 count and your viral load, especially if you're going to see a GP or any other healthcare professionals, or you're filling in insurance forms or whatever. It's really good to keep track of your results. And there are a couple of apps that you can download to your phone. There's IV Health Tracker or I Stay Healthy Tracker, which helps you track your results. If you just Google it, you can find those. NAM do something called a treatment passport, which is very simple, which is like a little book that you can just fill in your results every time you come and see the doctor. Or you might want to make your own spreadsheet. And that's the end of my presentation. I was just wondering if anyone in the audience had any questions.